Day is health is so important to our people. Help us, Father, make good decisions in the area of health. And Father, for those that are serving us overseas, I'd pray for you to watch over them and keep them safe. And those in our communities that are hurting for jobs or for sickness or for losing loved ones, comfort them, Father, as only you can. I pray for our chair, each committee member, and those in our audience, staff. Help us do good work for our people. Forgive us where we fail you. In Jesus' name I pray. Amen.
Next we have roll call. Please let us know you are here.
Bradley Cobb. Janelle Fulbright. Here. Bill England.
Here.
Bill John Baker.
Here.
Jack Baker.
Here.
Harley Buzzer.
Here.
Julia Coates. Here. Joe Crittenden.
Here.
Jody Fishinghot. Meredith Fraley. Here. Don Garvin. Tina Glory Jordan. Curtis Snell.
Here.
Chris Soap. David Thornton. Kara Cowan Watts.
Honey.
We do have a quorum.
Next, I'll seek approval of the March 15th, 2011 regular session minutes.
So moved. Second.
Have a first and second. All those in favor say aye.
You didn't ask for comments, Mr. Chair.
Okay, I'll ask for comment.
Thank you. Just need to note that I was in attendance via the video conference, but was not legally in attendance for the meeting for voting reasons.
I'm assuming you have that down. Now I will ask, all those in
Thank
favor, you're more than welcome. All those in favor of passing the March 15th, 2011 regular session minutes, please say aye. Aye. Any opposed? All right, those pass. Next we're to reports. Claremore Service Unit, I see George is not here, but Miss Vicki Snell is here. You are the next contestant.
Thank you. Glad to be here. Just a few things going on at Claremore. You have your report that we just wanted to bring you up to date on. March 29th and 30th, we had an unannounced survey in our laboratory. That's the way they survey and accredit our laboratories now. Those are unannounced. And I'm glad to report that we did very well. We have been without a lab department head for a year, and that showed us that our lab has carried on to the highest level, and the surveyors were very complimentary of their work. And we had a few minor deficiencies, but no major deficiencies, so we are accredited in our laboratory for the next 2 years. July 20th, the Indian Health Service will be sponsoring an IHS Health Summit. That will probably be in the Oklahoma City area, and they are encouraging any federal, tribal, and urban healthcare systems to participate. That will be July 20th, and we should have an agenda available for you hopefully next month to give you. Last month I talked about, some of the projects. We are in the midst of our mammogram project, and our mammogram machine is down, and we've made provisions on what to do with patients that have an urgent need, and then we are scheduling all screenings and hope to be back in operation with our new digital mammogram on May 1st. So we're online with that. In our recruitment and retention right now, our clinical director position is open. It will be open for, I think, through April 18th. And we are recruiting for, a clinical person to replace Dr. Mobley. So if you know of anybody, we encourage them to apply, and we are looking for a strong administrative individual as well, so to take over our medical program. In the recruitment retention area, we are recruiting for one CRNA, one internal medicine doctor. We had an intern that started yesterday, so that brings our direct hires back up to 3. We still have 1 vacancy. We have 2 vacancies and recruitments out for 2 OB/GYN surgeons, and we've hired an oral surgeon who will start the end of the month. This is a new service for us, so we are planning his needs and how to incorporate that into our system, healthcare system, and offer services for oral surgery. And that's about all I have. I guess we're still working under another CR this week, so hopefully we'll have a full budget next round.
Okay, any questions? Yes, ma'am. Counselor Watts.
Thank you, Mr. Chair. Of course, the employees at the Indian Hospital, because of the CR situation and budget situation, are concerned. I understand there's been some communication, and it's not within your guys' control necessarily, on the outcome. But you'll continue to communicate, I guess, with the employees?
Yes.
On expectations?
Friday, yeah.
Have you been able to maybe pull down money in order to maybe continue operations for a week or two, or what do we have any indication of?
Well, we sent out notifications Friday to all of our staff, and everybody would be in a working status. That's what there were some people who were identified as working in a no-pay status, and some who would be working in a pay status. And that simply is because of where their salary's paid out of. But everybody's working. There's nobody who would be furloughed in our service unit.
And then eventually they would get paid once the budget is
Yes,
final?
they were informed of that.
If it becomes very drastic, I think during Clinton's administration, there was a 6-week funding freeze. Do we have any means? I know that through the tribe, we have the emergency loan program, and that's potentially could be made available even to those federal employees, right? But do we have any other means? Some of the folks do live paycheck to paycheck on certain pay grades. That's just the reality of what's theirs right now, so.
Yeah, there was an email that was sent out by the area HR department regarding resources that were available through the Employee Assistance Program. And I don't know what all they were offering, but, they've been made available of some resources if the need arises. But I'm hoping that this was it. We will continue operations because we are essential and we will stay open as far as, we were notified Friday that there would be no furlough, but we would continue to work.
And I appreciate your candor, and tell George, thank you for sending you.
Okay.
You did a great job, Vicki, thank you.
Any more questions regarding Claremore? Thank you. Next, Cherokee National Health Services, Melissa Gower.
Good morning. Stop and think, is this morning or afternoon? Chairman Cobb, I would like to request that I yield my report time to Dr. Chuck Grimm, who I have asked to come and talk a little bit about services. Primarily because at the last couple of meetings, I've had lots of questions about direct care services, and he is the one responsible in our organization for all direct care services. So I'd like to introduce Rear Admiral and Assistant Surgeon General, Dr. Chuck Grimm. Thank you.
Dr. Grimm, 2 seconds. Counselor Jordan.
Melissa, before you do that, there was a question last night about the possibility of need for more funding to be put in the denture and eyeglass area. And we pulled the question from last night so that we could ask you today, because we hadn't been given any advice from you as a group leader whether there was a need to put more money into dentures and eyeglasses at this time.
We just recently got another appropriation for dentures and eyeglasses. I believe at the last...
Last night, I think you got
Melissa,
some more money.
if you could stand up, you're on tape, and the mic, I would like to thank you.
I'm sorry I wasn't there last night. I had a previous engagement, but there was a previous appropriation just last month for dentures and eyeglasses of $100,000. It was $900,000 in contract help and then $100,000 in dentures and eyeglasses. So that will suffice us through the remainder of the year.
Well, excuse me if I may, and you still have the floor. What we saw last night in the budget was there was a $100,000 appropriation. It brought the total to $800,000, and I think FYI 10 it was $1 million. Is that correct? So it's $200,000 under what it was, and I think that's where the question's going. So go ahead.
And I just wanted to make sure that you as the group leader would give us advice at one of our committee meetings should you see that fund getting low?
Sure,
And
okay.
you desire to put more money in there, you will let us know, is that correct?
Yes,
Okay.
absolutely.
So right now, you have sufficient funding there
Yes,
in that
ma'am.
line item?
Yes.
Okay, thank you.
Dr. Graham, you are back up.
Thank you. Good morning, everyone.
Morning.
I'm going to talk primarily about some of the services at the hospital. I'm the acting CEO at the hospital right now, as well as Senior Director for Health Services and overseeing the direct part of our program. One quick announcement Melissa wanted me to make is on April 28th at 10 a.m. we're going to have the grand opening of the dental clinic at Salina. Everybody's excited about that, our whole program. I'm a dentist too, for those of you that don't know me, so I'm excited about that from a professional standpoint. Also, last week we had our third survey by our accrediting body, DNV, Northgate Veritas. They come annually to survey us, and they look at the Medicare conditions of participation at our hospital and outpatient clinics. And this year also they did a first look at something called ISO 9001 standards. And that is something different than what our former accrediting body used. That something that pushes a quality management system throughout your entire organization and not just looking at your clinical components of the organization. They also visited the Salisaw and the Salina clinics. We all get accredited by that same organization. The way they have findings, there are severe findings that if you don't have it fixed immediately, they can potentially shut you down. We have had none of those in the 3 years they visited us. They have NC1, nonconformance is what that stands for, nonconformance 1 findings, which means there's a serious problem with some of your processes that could affect care. We have had none of those findings over the 3 years. And then also this year, our NC2 findings were down. Last year we had 15 NC2 findings. This year we had 10 NC2 findings across our health system, and they're very simple. Most of them are very simple things to fix. I'll give you one example. We have department scopes of services for all of our clinics in the hospital. That document was not fully complete because we thought they were going to be here in May, and they showed up in April. They come on surprise visits. Had they come next month, that would have been done. Our organ procurement contract just needed to be updated, things like that will be very easy fixes. So overall, it showed that our health system was in outstanding shape. All of our clinics were prepared and ready to be visited, but they just visited the 2 outlying clinics. And each year they've come, they've been rotating among the outlying clinics that they visit, but they visit the hospital each year. And they had 4 surveyors that were here on site. I want to talk to you a little bit about some of the new services that have started to be offered at the hospital since the tribe has assumed operations of that. The staff are very, very excited about that, and the patients are very, very excited. And I ought to add that as the surveyors went through the hospital, they would talk to both staff and patients. They said probably better than any rating that we could give you, every patient we stopped in the hallway were very, very proud of the facilities that the tribe had that they were able to go to, and they were very proud of the staff that was there providing them services. So they said that is better than any kind of good grade that we can give you. They also said they heard staff talking in the hallways as they walked around, and they said it seemed like a very happy place to work. They said a lot of places they go to, the staff don't sound very happy in their work, and so they gave us some sort of subjective comments at the end that made us feel good in management, that we're providing a workplace that our people are glad to come to work, and that our patients are very happy to be able to provide services there. We had In the last 12 months, our outpatient visits have gone up. We had 310 outpatient visits just at the hospital. That was a 10% increase from the 12 prior visits, or 12 prior months. We had 3,036 inpatient discharges. That's not days, but 3,036 different patients that had been to the hospital to be an inpatient there over the last 12 months, and we've delivered 788 babies over the last 12 months. I should point out that the Cherokee Nation Hastings Hospital has the second highest number of births of any hospital in the entire Indian Health Service system. We consistently run second prior, and that's been that way for a number of years. Most of you probably know that we have 60 beds in our hospital. And the big news item right now that we have going on are the renovations that are occurring at the hospital. So I wanted to talk to you a little bit about them. And many of you were there at the groundbreaking. If you haven't been out there lately, you ought to come out and just see what those areas look like now. There are two external pieces of construction going on right now. One of them is going to be a combination warehouse and office space, and that is behind the hospital. And it will have a connecting covered walkway, not a walkway, but an enclosed walkway for people to come in, and that will also be where the emergency room entrance will be. There'll be a drop-off for people to drop their family members off there at the ER. That building is about 19,000 square feet, and then we're going to be adding to the podiatry and physical therapy building, which is, if you're looking at the campus, that far left building, not a part of the hospital, but the second and the furthest out. It was a 4,000 square foot building, and we're adding 8,000 more square feet to it. And it is going to house orthopedics, podiatry, and optometry. Those sorts of renovations are going to start a cascade of events that I'll talk to you about as soon as I finish talking about the renovations. Once those two renovations get completed, which are external to any of the current structures, we'll begin moving some staff into those buildings. As we move staff into those buildings, we'll free up what is going to be our new ER, which is currently our warehouse, and then it'll free up a number of office spaces, and that will be an urgent care facility. So we'll have in that back hallway there, as you come into what is the current ER, if you come into that back hallway and turn right, the new ER will be on that side. Right across the hallway from it will be urgent care. Both of those are going to be bigger than our existing, what we call it now is adult walk-in or fast track. That type of care is all going to be moved up to that urgent care area, and it's going to have 12 exam rooms and 3 treatment rooms. So it has more capacity than our current adult walk-in. Once we move our ER staff and our adult walk-in urgent care people to those areas, we're going to start some internal renovations that will expand space. That adult walk-in area where you see so many people coming for emergency type visits on a day-to-day basis. Down there in that area is also orthopedics and optometry. And you heard me say we're moving those out into that new building that's going to be the physical therapy building. So that whole area down there is going to get renovated, and we're going to turn it into a primary care practice area where we will have physicians that will have impaneled patients so that we can start providing more continuity of care to our patients, so that we will get a patient assigned to a provider, and with the exception of if that provider happens to be off on a vacation or something, they will try to see that provider. And even if they go to urgent care, we're going to try to set it up such that each of those providers down there will have some open slots, so that if one of their patients comes into urgent care, if it's at all possible, we'll send them back to their primary care provider to be seen. Once we've moved, and we'll be moving our internal medicine or adult medicine department and our family practice physicians down into that area. Once we free up the internal medicine department, we'll move our pediatrics department over there. That'll almost double the space that our pediatrics department has, and they are sorely in need of space. If you've ever walked into that area where pediatrics is, it's usually packed. So we'll almost double the space they have, and we probably won't need to add any new staff to them because over the years the staff numbers remained constant or increased, and we'll be able to spread them out, give them more exam rooms, and that's going to increase access to care without really costing us any new staff. Once they move, women's health will expand from where they're at into the pediatrics area also. So women's health is going to expand and have more space. So these renovations that we're doing are starting what will be probably a 2 to 3 year set of expansions that are going to grow the ability to have more patients access our care. When the tribe assumed operations, the number of outpatient visits were between 200 and 220,000, I want to say. Just with the new staff we've added, we've already got the number of outpatient visits up to 310,000, as I said, over the last 12 months. We've added one new orthopedic surgeon and an orthopedic physician's assistant. That orthopedic surgeon happens to be a Cherokee female. She's the only Cherokee female orthopedic surgeon in the entire country, and she does hips and knees primarily. So we used to have to send all those types of joint replacements out. We have the capability to do that in-house now. We've hired 2 new anesthesiologists and a new registered nurse anesthesiologist. That now has upped our anesthesiology department to take care of a situation that we used to get a lot of complaints on, was when mothers were giving birth, they could not get epidurals on demand.
Dr. Graham?
Yes.
Let me interrupt you. Councilor Baker has a question.
Yes, sir.
Does that mean that the hip replacements and knee surgeries will not be contract health anymore?
No, we still have more than we can see internally, so there will be some still that have to be sent out. She can only do so many.
The one she does won't.
No, those are not having to be sent out now. She takes care of those in-house. But the demand for those types of joint replacement surgeries are still greater than we have capacity for. But we've reduced the number now that we have to send out. Same way with another new service that I'll mention that we just started in this past year, our sleep studies. We now can do in-house sleep studies. We have a 24/7 respiratory therapy department. It was a new department. Yes.
Does that now mean that somebody in Muskogee that lives outside the 14 can come to Hastings for a hip replacement?
Right now, we have greater demand just within our 14 county jurisdictional area, and right now we're withholding that to within those 14 county area. So what would be our CHISDA, our contract health service delivery area?
Okay.
The respiratory therapy department that got added after the tribe assumed operations, there was not one in existence at Hastings prior to that. And now we have respiratory therapists on duty 24/7 to serve the ER, neonatal in our newborn nursery, or anywhere on both inpatient or outpatient floor. When we added them, we also took a look at contract health service dollars that were being spent on sleep studies. And with the 24/7 respiratory therapy department, we felt like we had the capabilities to do in-house sleep studies. And so we've taken 2 of our medical surgical rooms, turned those into sleep study rooms, and we're now doing 7 days a week, usually at night, but if a person is like a shift worker and sleeps during the day, we'll do sleep studies during the day for people like that. But we are now saving monies on those sleep studies that we have to send out. We're able to do usually 14 a week in-house because there's not that many daytime shift people that we end up doing, but that has significantly helped some dollars in our CHS budget. We also have a new psychiatrist that we've hired on full-time that's enhanced our behavioral health department. We have two new OB-GYNs and a new midwife. We've hired one new surgeon that's already on board, and we have a new surgeon that's coming on board in April, as you know, or excuse me, September. Surgeries had been one of the things that were very backlogged when the Indian Health Service ran the program, and we've made concerted internal efforts to improve the efficiencies of our operating room, as well as hiring some additional staff that we needed to be able to crank out more surgeries. We've also hired 2 new internists. We've hired 3 new family practice physicians, 3 new emergency room physicians, and a nurse practitioner additionally for adult walk-in, as well as a new podiatrist. Most of those, as you noticed, that as I read them off, are specialists. We had a good number and a good working set of family practice and internal medicine people, and a lot of the additions that we've made since the tribe has assumed operations have been in the specialty areas to be able to provide more services to our patients right here on site that we used to end up having to send out. One of the other things that the patients have really liked since the tribe has assumed operations is that we now have a centralized formulary across our system for drugs, meaning that whenever the tribe assumed Hastings, all of the pharmacy and physicians on the Pharmacy and Therapeutics Committee got together. Our leadership, Melissa and Gloria, decided that we would have a standardized formulary. What that meant for the people here in Tahlequah that went to Hastings or that came from the outlying clinics is that Hastings ended up adding 142 new drugs to their formulary to allow patients to be better served here and not have to go to other places to get them. Just in the last 12 months, we have had over 441,000 prescriptions filled at the hospital. 229,900 of those were new prescriptions, and that's up 7.3% from the year before. 211,639 of those were refills, and that's up 13.9%. Our clinics are now doing, the hospital and clinics are doing mail order refills for patients that want to do that, but we are working on a centralized mail order refill center that's going to be at Muskogee, and once that's up and operational, it'll take that refill demand off of the clinics for those patients that want to, and we're going to try to, urge patients to do that. It'll be easier for them, and it'll also allow those patients that are in the hospital or the clinics to have their prescriptions refilled quicker. They'll get them more immediately because they aren't going to be competing with patients that are just coming in for refills only. And so our refill system, we hope, is going to be improved whenever that center opens, but we've asked the clinics and the hospital to start already providing that service to those patients that want it, so they'll start getting used to that. We also, Melissa's probably told you about this before, but I want to highlight it one more time. A new surgical service that we've started provided is bariatric lap band surgeries. We had a physician that got trained and certified in that. We have patients go through, it's usually about a 1-year program called HELP, Healthy Eating for Life program. And once they get through that, if they're still in need of a bariatric type surgery, we are now doing bariatric lap band surgeries. And the lap band surgeries, the reason we chose those versus some of the other types that are out there, they're safer, they're removable if necessary, and the surgeon can work with the patient to adjust things, and it is not as permanent as some of the other types of bariatric surgeries out there. We're looking over the course of the next year or two to further expand those HELP clinics, to more of the outlying clinics so that we will be getting more and more referrals in for lap band surgeries to those patients that need it. We also have changed in this past year to what's called a hospitalist system. We used to, prior to this, have any doctor that was seeing a patient would be the one that followed them in the hospital if they had to be sent to the hospital. Studies nationally and a lot of hospitals nationally are moving toward a hospitalist system because it's better continuity of care. It's people that are highly trained in the delivery of hospital-type care. And what it means is we took 4 of our internal medicine specialists, we moved them to do only hospital-type care. So there's one 12 hours in the day, 12 hours at night, and they rotate like that. That way, there are only a small number of our physicians that are treating patients that are in the hospital, so they're getting more specialized type care, if you will. Any of the patients that are seen by a primary care provider, that provider can still come up and round and visit with the patient if they so desire, but the hospitalist is in primary charge of their inpatient care. And because most of our patients are coming from our outlying clinics or here in Tahlequah, when they're released to back to their primary care provider, because we're all within the same system, they have all the information of what occurred and can consult with the hospitalist on that care if needed. Also, that leads to our electronic medical record and the fact that we have consolidated our databases among all of our clinics in the hospital. So what that means is if anyone is seen at one of the outlying clinics or the hospital, when a doctor looks at your record, they now have the capability to see if you visited one of our other clinics and what medications you are on and things like that. That's going to enhance continuity of care. It's going to lead to safer and better care for our patients, and that is something that still the Indian Health Service has not done. They've not been able to consolidate the databases either across the nation or even within a service area, and so that is something we've been working on very hard for the last year, and we're in the final phases of consolidating that. Also, the Accountable Care Act made funds available to incentivize hospitals, group practices, and individual providers to use an electronic medical record. We have our providers signed up, and we are applying for those incentive funds, and those will bring new funds into our system that we will further use to help enhance the current electronic medical record we have, or look for one that can potentially better fit our needs. We are actively looking at some of the top-of-the-line medical record systems that are off the shelf right now that we currently don't use. Of course, I think most of you have seen the new signage that's occurring out there on the campus, and the branded signage, the cultural artwork that we've put in to the hallways out there. Can't tell you how many patients stop and look at that and comment about it on a daily basis. We bought all new hospital beds, patient waiting room chairs, and waiting chairs within each inpatient room. We have a new mammography service on site. We used to have mammography services. It was either one time a month or one time a quarter when a van would come out. Since the tribes assumed operations, we now have a digital mammography unit on site and 2 new ultrasounds placed right by that to enhance the level of preventive services that we can give to our female population in the way of cancer screenings with ultrasound and mammography. One last thing, and I could talk for a long time, but I'm going to just stop in just 1 sec and see if you have any questions. But one last thing I wanted to say is that we have continued to see an influx of patients as we've added these additional services, as we've added more physicians and dentists and podiatrists and you name the type of provider. we have steadily, and this even includes with Muskogee opening, and for a while there, Muskogee was starting 500 new patient charts a month. They're down, they've dropped down to what, 350 or so a month now. Even when Muskogee opened, the hospital was seeing right around 400 new or 400 reactivated patient charts a month, for a total of between around 600 to 800 new or reactivated charts a month. So the demand is still out there. This expansion that we're doing is going to help. We don't really know if it's going to take care of all the needs or not, but it is going to give all those departments that I talked about more space. It'll give ER, urgent care, orthopedics, podiatry, physical therapy, adult medicine, pediatrics, primary care, and women's health. Every single one of those departments are going to get additional space as a result of all the renovations that are occurring out there right now. So I will stop right there and see if you all have any questions about things that are going on at the hospital.
Councilor Baker.
I had occasion this last month to be at the hospital several times, and I don't think that Johnny Keener and his family could have got any better service any place in the country.
Thank you.
And I thank you for that.
I will tell the staff that. We get surveys that are done monthly that get mailed out by a group called Press Ganey. Most hospitals use that group to get satisfaction surveys from their inpatient patients. And we continue to have extremely high scores. And I didn't talk to you about some of the other scores from a quality perspective that we track, but many of those are at or above national standards and averages. I mean, I think that everyone in this room has a right to be very, very proud of what's going on in all of our health clinics. In fact, I was on my way to a national meeting and was sitting with the chief medical officer from a big health system headquartered out of Kansas City that has hospitals and clinics all over the nation. He was going to the same meeting I was going to. He heard where I was from. He knew about the work that we had been doing. Melissa or Gloria, probably one, have talked to you about improving patient care or innovations in planned care, the IPC initiative. The Cherokee Nation consistently had some of the highest measures in that throughout any Indian Health Service or tribal clinic in the nation. And he was talking about how we could be a model for the nation and how to deliver health care to a patient population. And they were very thankful for some of the projects that we were involved in. So I'm very, very proud to work for this system, and you all who help oversee us and talk about our funding and things that you do in the council should be very, very proud of our system. It is nationally known, not just by people within the Indian Health Service world, but by external people and people from other countries as well.
Councilor Buzzard.
Dr. Grimm, I'm going to ask you a question, and it has to do with referrals from our clinic, actually from the J Clinic, that's where I live in J. And the best way to probably answer the question is, I had a patient that called me, and a year ago she was diagnosed with some problems. It went a whole year. She got referrals to go to a specialist in Tulsa to get this diagnosed. Well, then after the year is up, then she gets another referral, says she's going to come to Hastings Hospital for the surgery. My question is, how do we put priorities on who gets the surgery when at Hastings Hospital? Do they go into a pool, say 50 that needs a surgery? And how do we determine who's going to be first if the case she had is grown by 80%? Now, obviously, she needs to get in real quick.
Let me
So how
interject real quick. I want to make
I'm
sure.
not mentioning any name.
No, I don't interject. contract health or stuff we do in-house, or both?
Both.
Both.
Yeah.
I'll answer for both.
Okay.
And if I don't say it well enough, Melissa can throw in 2 cents, because this is very important. It's a very important question. I talked about the number of new surgeons and OB-GYNs and podiatrists. All those types of people can do surgery, as well as an oral surgeon that we've been allowing more surgery time. We've been working really hard to get that list down, and the list that we have that I talked about are elective type surgeries, but on some types of cases, if they are elective too long, then they become emergent, and that's kind of what you're asking. The bad thing about having a list like that is if it's too elective and it's never going to get urgent, you get bumped by urgent cases. I mean, we save room in our surgery schedule every week for cases that are urgent. If somebody comes in and the surgeon or the ER says this is a stat surgery, it's got to be done now. It doesn't matter if it's in the day or in the middle of the night. We have teams that come in. We have the OR capacity to do those sort of surgeries. We're working constantly, and we've just recently sent out letters to people to see which of them still need certain surgeries. And right now we're looking in particular at colonoscopies. We had a big colonoscopy waiting list. We're sending out letters to see, have you already had it done? Does your primary care physician still feel you need it? And we have had 2 of our physicians who don't even really work in the surgery clinic. They've been coming in and doing histories and physicals on patients like that to get them prepped and ready to go for our surgeons to do surgery. And to start working that list down, we're not only using our OR suites, we are renting time, if you will, of OR suites down at Tahlequah City Hospital. They don't keep theirs busy all the time, and so we're renting suites down there to start trying to work down some of that list. Now, I would tell you, if she calls you and says, I think I'm getting worse and nobody's called me, you call me, or you call Dr. Nolan, our medical director, or Gloria or Melissa, and we will make sure that her case gets looked at. But in general, we stay in close contact with CHS, and if we start to see one kind of, number of cases of a type get too long that we know we're not going to get down, we'll go to CHS and we'll try to get some of the more immediate cases done with CHS funds, but we're trying very hard to control them with the number of surgeons and the fact that we've been able to rent space, if you will, from TCH.
And the other thing, and I understand what we're trying to do here, is she was referred to specialists in Tulsa, and they recommended the surgery, but then she gets referred back to Hastings Hospital, and I realize we're trying to do this to save on the expenses of the thing. But I guess what she didn't understand is it took her a year to get this far. And I guess if it's happened to us in the video, we feel like it's the most, and it wasn't elective surgery, it was something that needed to be done. And she was frustrated, so Melissa's going to be, or she is aware of it, and hopefully we'll get taken care of. And then I'll just refer her to who I
do, because we'll look at them on a case-by-case basis. When you have that many patients coming through, we try not to let any slide through the cracks. We have a whole lot of safeguards that are in place, but if something like that ever happens, just call.
And it seems to me like sometimes, and I don't want to say at our clinic, but at some points, the doctor will see a patient and they give them a referral, and that's the end of it. They don't follow up to see if this patient ever got the services that he needed, because what they're saying, well, we did a referral, so it's out of our hands. So, and I know the patients have some responsibility on themselves to follow up on referrals. So, okay, well, I'll pass that information.
And we are working on the improvement of that system too, from when it hands off from a physician in our system to the contract health system, if you will, and they need to be referred outside. We've been doing management reviews of the CHS system throughout the hospital and the clinics, and we're trying to make sure that we don't, drop the ball between a referral and when a patient gets an appointment with an outside specialist that they need to go to. That is something that we know has occurred in the past. We're trying to work on that.
Sure, and I understand, we're both saying something. Thank you.
Are there any more questions? Counselor Jordan?
Chuck, I use the adult walk-in there at Hastings. Used to use it every 30 days, now I think I'm on a 90-day rotation. And by the way, they do an excellent job, they have a very good doctor there. But I've noticed that we're getting a lot of, seems like they've gone to a clinic, but they couldn't drop in that day, so they have to come to Hastings. And I'm just wondering, is there something on the drawing board to eventually open up more slots there in the clinics for drop-ins so that we ease the burden of the adult walk-in there at Hastings?
And Melissa may want to add something to this too, but there are a couple of performance improvement projects that we have going on right now around access to the clinics and to the hospital. And so we're looking at that particular issue. Muskogee quickly got, filled to capacity too, and they're having to turn patients away that are there to either make an appointment and they can't get one until it's too far out, or they can't be seen that day for a walk-in because they're already booked. So we're looking at perhaps a system-wide way to deal with that. We've talked, don't hold me to this, we've talked everything from like a centralized call-in place where we could direct a patient to a clinic that might have some openings if they could travel there, to whenever we get this expansion done at Hastings, we'll have this whole area down there where adult walk-in is now, and ortho and optometry is going to be primary care practice. That's going to increase access there. And then we will have that new urgent care room that'll have 12 exam rooms and 3 treatment rooms for in case minor treatment procedures need to be done. For those people that are close enough to Hastings, we hope that when we get all those primary care patients impaneled there, and hopefully that some of them will be able to see their patients that are coming into ER urgent care if it's not a true emergency. We're hoping that urgent care, for at least those that are close enough, can be that steam valve, if you will, to let off the steam on the system. That is going to be, we have plans for that to be open from 6 a.m. until midnight. So that means the ER would only be taken care of midnight to 6 a.m. by itself in our whole system. So there would be a 6 a.m. to midnight urgent care that could be accessed by anyone that, could get here. And I know transportation is a problem for people, and with gas going up, that's even a bigger problem. But we know it's a problem and we're working on it. One of the things that we're doing is we have about 16 system-wide sorts of improvement projects that we're working on in areas that we would like to improve. Just the ones that we've been able to quantify have a return on investment of around $7 million, we're estimating. And some of that's going to be with increased access to care, because several of them are access to care things that we're working on. We know it's an issue, and what we don't know is how big a place do you really need to build to be big enough, to see all the people that want to come, because boy, Muskogee was big, and it's already, having to turn people away at times. Veneta will help when it comes online. It's going to be almost as big as Muskogee. I'm sure Melissa has shared that with you in past meetings and some of the photos of what it's going to look like. It'll be like, 90,000 square feet, and Muskogee's 105,000 square feet, if that gives you an idea. So Veneta will help draw some load off of some places too.
Let me ask you, when you get done with all the improvements that you've been discussing, what will be the square footage of our clinic per se?
It's right now, the hospital's 158,000 square feet. The external square footage of what we're doing is 27,000. So you'd add 158 plus 27, but we're turning what was warehouse space and just office space into clinic space now. That new ER and that new urgent care were non-clinical space. So you could really, that plus what the old ER is, and I don't think I told you what that's going to be. There'll be 6 pre-op areas there because they're right by an elevator that goes straight up to the OR. There'll be a new pharmacy back there for patients that are seen in ER and urgent care so they don't have to go back to the middle of the hospital for pharmacy. And then that's where the surgery waiting room will put, for those of you that have ever been in surgery now, if you or family members, it's up on the 3rd floor. It's kind of in the hallway. It's not very comfortable or private. So that old ER is going to have a waiting room for our surgery, the families of our surgery patients. And the pre-op will be right there on the same floor with them, so they get ready. That's also going to help us expand the capacity to do surgeries because we have had days where our surgical teams and the teams that turn over the rooms to get them ready for new surgeries are so efficient that we have still too many people in post-anesthesia care unit that they can't push any more people out. They got to wait till they can clear them out of PACU. And so we're adding 6 new pre-ops that'll allow them to turn the upstairs, which was pre-op and post-anesthesia, into post-anesthesia only. So that is going to help us increase the capacity, hopefully Harley and others, to even push more surgical patients through the current number of rooms we have.
Now Chuck, that 185,000 square feet, does that include the hospital as well as the clinic?
Yes.
If we separate the hospital off, what will that leave us with clinical services? Do you have any idea?
The hospital, I can get that for you, just really the 3rd floor. So everything below that is ambulatory clinic space, if you will, or ER. There aren't, besides the renovation to OB, which I talked about, we're going to totally renovate that whole area. New floors, new paint, new bathrooms, new beds, the back headboards that you see that are kind of old, and they're going to be wooden and very, private sector, nice looking for our families and moms. Once we get that renovation done internally, that's a renovation that's not going to add any square footage to us, but it's going to make it a place we hope where our people want to come and are proud to come, and we hope we'll, instead of 788 babies, next year we'll have 888 or 988 babies there. We'll have added, to fully answer your question, let me see, the 27,000 is new. Internally, that the new ER, the new urgent care, and then the pre-op and pharmacy, that is an additional 16,000 feet that we are turning into clinic space, if you will. And then the 11,000 square feet of postpartum and labor and delivery on the 3rd floor creates no new space or anything, but it renovates the nursery and all the postpartum beds and the labor and delivery area. So
when we started with Cherokee Nation taking the reins there at Hastings, I was under the impression, in fact, that I was told that we would eventually separate hospital and clinic. It sounds like we're not doing a complete separation, but we're renovating and adding to. Is there a point in the future where we're contemplating a separation of hospital and clinic?
And do you want to answer that, or do you want me to answer that?
Well, you're doing fine. I
If I say something wrong, stop me here.
And I understand that that's not a concrete thing,
Yeah.
but I'm just wondering, are we still contemplating?
What we've talked about is, you know, that we own the 45 acres on the back side of the parking lot. We've been working with a design firm to look at multiple design plans for that property. We would like to get a joint venture with the Indian Health Service like we did with Muskogee and Bonita, where the tribe builds the facility and the IHS gives us the money for staffing and operations. That would be ideal. But if they don't ever make that kind of money available and we're not successful at getting it, we are looking at phases of what to do. And so probably what we've talked about with you in the past is that when we start building on that 45 acres, we've looked at the potential of building a huge outpatient facility only. And we would leave the inpatient where it exists right now. There also is the potential that on those grounds that the outpatient and the hospital could be in separate buildings. So, we've looked at multiple plans, and it'll just, I think, take time and money and work with, the administration and the council to decide, if no new monies are going to come down from the Indian Health Service that we can apply for, where can we get the biggest bang for our buck next? Is it to build a big outpatient facility? And then we could potentially, in our current one, we could use like more OR rooms. There's no place to bump and build more OR in our current facility. So if we did get rid of some of the load out into an outpatient facility building, we could do, we could build more surgical suites. We could do more things, in-house now. Hire a few more surgeons and, get some of the elective surgeries down so that there aren't the problems that were brought up earlier. So that's probably what was talked about earlier, is that, this is what we're doing right now is short range. I mean, you heard me talk about the numbers, and they keep growing. We're still having to turn some patients away, or they're seeing their chronic care down in adult walk-in instead of with a impaneled primary care provider that is the one you see all the time, which is the model we're moving toward, which is what many of the clinics are already there. The hospital's not there yet. So this is short-term fix. What we're doing right now, it's going to give all those programs increased space. We'll be able to see a lot more people. But in 5 to 10 years, what you're talking about is on the table.
And my last question, is the 45 acres sufficient for expansion for the future? Because I understand we passed on 12 acres that was available. What you all refer to as the Burchett property, there was an additional 12 acres there that I understand was available, and we didn't,
We
and
tried.
that may have not been you all, it may have been facilities, but
First we didn't pass on it. We were actively trying to get that. We just weren't the successful person to do
Yeah, I
that.
understand the city hospital.
So, I've visited, of course, we have a close relationship with Tahlequah City Hospital, and I've talked to them, and, they're open to working with us if we need to use part of that acreage. But currently, where we're at in the process is that we are currently developing site plans for the 45 acres to see what all is buildable space, and out of the buildable space, what all do we want to place on that acreage. And so that's where we're at in the process. So for me to completely, my answer to your question is, I think we're fine with the 45 acres, but I can't definitely say that until I get the final site plans back from the architect showing all of our sites and where those are placed on buildable property.
Okay. And then, I said that was my last question. I had just one more.
I had one thing. I was surprised as we were looking at these plans about the Hastings campus right now. when you look at it compared to the whole 45 acres and the parking lot, I mean, where we're sitting on now looks tiny. I mean, I was surprised, it's like, wow, is that all the space we are taking up right now? So there's room for a lot of buildings, and we've looked at concepts that are sprawling, and we've looked at concepts that are more urban, you know, that build up and have sidewalks and are closer. So, you know, I think we can do what we need to. It just depends how we build the buildings there.
Okay, the last question is, and this has been a concern to a lot of people that have called me. Where are we headed on parking? We're just.
I forgot to mention that. I'm glad you asked. Well, if any of you have been out there lately, you notice we graded a area out back there and created a number of new spaces on that new 45 acres. Part of that was because the construction company took part of our parking on one end, and then part of the staff parking behind the hospital is now gone because they've, you know, fenced it off and are doing the construction now. Part of the new construction, where that big building is, the one behind, it's going to be 19,000 square feet. There'll be 2 bays for big semis to back into the warehouse. And then from the back part of the building on around and then wrapping down back toward the hospital, there's going to be 200 new parking spaces added. So, I mean, that's, I think probably at most, maybe there was 40 or 50 cars being parked back there, you know, on a busy time. So it's going to create a lot of capacity there. And the fact that we have all that acreage out there by the physical therapy and that expansion, as well as the 45 acres. If we need more parking, we can do it. But one of the things, again, that we're looking at for the future is the potential for a parking garage, so people can be closer, you know. But
We're getting them so far out, we're almost gonna have to have a shuttle
we've
or some train or a little.
we've actually been looking at that. Melissa had us talking to a group, 2 things: a valet service for our elderly or handicapped, or really anyone that wanted to use it that was coming in. And then also we've looked at the potential of just the hospital buying some like nice multi-seat golf carts and having our security and some of our other staff that are available to be just circling the parking lot and asking people if they want rides in. So we're looking at both of those options
I
right
have
now.
actually recently seen people have to stop and rest to get from the back of the parking lot
It's a long
to
way.
the front door, and if they're elderly, they're actually having to stop. We're gonna have to do something because they're not
Yeah.
able to get down to the front door anymore.
We're looking
If
at
they're
both of those
alone,
options
especially if
right
they're
now,
alone.
whether to do it ourselves, you know, with our own staff, or whether to hire a service. The Chickasaws have a service that they use, and we had them come up and look at providing that service to us, and they were overwhelmed with the volume that we had compared to what the Chickasaw has down there. Same way, we had a consultant come in to work with our housekeeping department recently. He was overwhelmed at the volume of patients that we had coming through there on a daily basis. So we're looking at both options, maybe a contract out of a valet service, or us providing it with, you know, nice golf carts. And I did not mention, but the expansion of that one building, if you're looking at the hospital, the one to the far left, we are going to put a covered walkway from that building all the way back to the hospital, and we'll have awnings that come out that allow people to drop off under a covered area, and we're going to add an awning in the front of the hospital so that it'll be covered, so that in bad weather there'll be covered walkways now too for our patients once you get in to that area. If you're way out back, it's still a long walk.
I think they'll come nearer using the golf carts than they will the valet because they like to go to their cars.
Yeah.
A lot of times they'll check in, then they'll go back to their car for whatever reason and wait, and then they'll come back in when they think it's nearing the front for them to get in and
We've
see the
actually
doctor?
kind of been leaning that way too, to tell you the truth, as we've been studying both options to getting our own. We think it'd be more economical in the long run, and it would be right there when you need it and take them right to the car. And you're right, a lot of people don't like to give up the keys to their car to a stranger, you know, so,
Excellent presentation, thank you very much.
thank you.
Speaker Fraley?
Just a quick comment, Melissa and Dr. Graham, I've had several good compliments about your mail service, particularly out of Salina. In today's economy, with the fuel prices as they are, the elderly in particular really appreciate that, so thank you. Thank you.
Thanks.
Melissa, I wanted to state real quick, I had the opportunity to be in Nowata County and discuss some glowing reports from constituents on pharmacy in Nowata.
Thank you very much, appreciate it.
I believe there's no old business or new business. We're down to announcements. I do have a request on the table to move Health Committee to 2 p.m. on Mondays. Do we have a quorum in there? Yes. I have a suggestion on the table to move Health Committee, to move this committee to 2 p.m. on Mondays. Do I have a motion for that, or
Does that just leave one?
Does it then need to go to rules?
do you want it to go to rules? Since we are in Health Committee.
I had
I'll open
pulled,
this up to discussion for right now. Go ahead, Councilman. Buzzer.
okay, well, I pulled the Community Services Committee off of that because it just felt like that, we're so close to maybe new people taking seats on there that I didn't want to disrupt it, so that's why I pulled that. But I think probably leave it up to the committee, what we're going to do.
Councilman Baker.
And I think that any changes should wait until the new council sees it.
I don't have a motion on the floor, so
Might I suggest that, I'm not sure who made the recommendation, but could I suggest that we just move it to rules so that we have a full group of...
that would be my recommendation since we're kind of,
Kind of light
Low
on
here.
who's left.
yeah. Let's, I would like to move that on to the topic of discussion for rules at the end of the month.
Did you
Go ahead, ma'am.
withdraw or did you table?
No, I withdrew
Oh, okay.
so it could go back, whoever wants to sponsor it for rules, that's how I see it. So,
So you want to add that also?
I don't want to be the sponsor of it, but
Okay.
I'm certainly open to it.
That's fine. Let's move that as a topic of discussion topic for rules at the end of the month. And any other
Were
comments?
we going to put both of them on there, was that what? we
Rules
did
and
for
resources? Is that what you're, or set and sub, or what? do
I
you-
would suggest we go ahead and put both of them on there for discussion.
You're talking about resources also?
Community service.
I mean, community service. I keep saying resources. Community service.
If that would be possible, we just add them both on the rules.
Let's add that both to rules for the end of the month discussion.
Put you as sponsor?
Sure.
Move to adjourn.
We have a motion to adjourn.
Second.
And announcement, this next meeting obviously is scheduled for May 17th at 11 a.m. That may change after rules. We are adjourned.